Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Joseph O'Neill, also known as Jake O'Neill, and today we're diving into compartment syndrome. So in particular, Dr. O'Neill and I are going to discuss diagnosis and clinical presentation and picture of compartment syndrome. Dr. O'Neill is going to discuss various surgical considerations, and we're going to chat a little bit about rehab considerations for compartment syndrome as well. So this is a great episode that really dives into a lot of detail, especially on the diagnostic and surgical side. I know you're going to love this episode. Jake, welcome to the podcast. I'm super excited to work with you today.
Thanks, Dan. It's great to be a part of it.
For people who aren't familiar with you, or maybe they've never heard of Rothman Orthopaedics, would you mind filling them in a little bit about who you are and all the amazing things you're doing up there?
Yeah, so we're a big orthopedic practice, primarily based out of the greater Philadelphia area. We have well over 100 physicians, combination of orthopedic surgeons, but also non-operative sports specialists, non-operative spine physicians who are primarily trained in physical medicine and rehabilitation. And, our kind of core or central part of the practice is based out of the Philadelphia region with extension down into South Jersey and the South Jersey shore. But we have since kind of spread our wings and extended into the New York City market, North Jersey, as well as down in Florida and primarily the Orlando area. So it's a practice that has significantly grown, particularly over the last 5 to 10 years. But primarily, we're essentially an orthopedic practice only. We are a private practice, but very heavily involved in academics. Within the Philadelphia area, we're heavily involved with and affiliated with Thomas Jefferson University. So we kind of consider ourselves like a private-demic model. So we're a private practice, but heavily involved in academics and research and teaching, which I think kind of helps us stay on the cutting edge of treatments.
Yeah, definitely. And not to mention, you're one of the best in the country. And you kind of missed one of the most important parts about that, Jake, is how you fit into that whole thing. Because, I can speak from what I've seen. You're a pretty impressive surgeon. You're in my top list as far as foot and ankle guys go. So, tell us a little bit about your practice and what you do.
Yeah, so I'm in my 5th year of practice. I started in 2018, so just about September. So just about to start my 6th year in practice. I trained at Jefferson Hospital in Philadelphia with a lot of the Rothman physicians, and then did my fellowship in Baltimore with Lou Schoen, Greg Guyton, Stu Miller, and Jake Wisbeck at Union Memorial. And then came back to Rothman immediately following fellowship and have been there since. So as you mentioned, I am a foot and ankle specialist. I do a lot of general trauma call though. So, I'll essentially do anything involving the lower extremity when it comes to trauma. But from an elective standpoint, my focus is foot and ankle. I got into it, I think I liked everything in orthopedics for the most part, but I always loved the variety in foot and ankle. You have a variety of patients, a variety of conditions that you can treat. And you have a little bit of everything that all the different fields in orthopedics offer you, all bottled into one. It's a field that always keeps you on your toes. And I really like the variety, but I think also I had some really great teachers that I learned from, specifically Steve Rakin, who recently retired. Dave Pedowitz is my division chief at Rothman. He's the head of the foot and ankle department. And I think, your predecessors and your teachers go a long way in terms of influencing you. And those two definitely had a huge influence on my decision to enter or to specialize in foot and ankle surgery.
Yeah, no, that's incredible. And that whole region is very difficult to understand at first. There's so many little bones and little joints and structures kind of tucked in that area. There's a lot going on, and I feel like people don't often recognize just how important the foot and ankle are until it's injured. And it's like, oh yeah, every step I take, every single thing I do, I kind of need this. It's funny, we were talking just a few minutes ago before we started recording about how we feel like a lot of people just kind of miss the importance of the foot and ankle. And a lot of things that they do, whether that's training or just, day-to-day life. Is that something that you find a lot yourself on the clinical side of things as well, or?
Yeah, without a doubt. As you mentioned, you can't get anywhere without your feet, and it can be an unforgiving structure. I mean, like you said, it's a multitude of bones and joints that can be very unforgiving from the standpoint of injuries. And obviously, you're not going to get anywhere with your feet. And I see countless numbers of patients who come to see me, obviously, because they're having pain in their foot or their ankle. But then incidentally, they'll know, well, my knee, has started to bother me. And it may not even be on that side. It may be the other side, or my hip, or my low back. And everything is connected. So you start getting a problem in the foot, and you start to alter your gait to try to accommodate that. You're like, oh, I don't think it's anything worth seeing anyone about. And then you start to alter your gait. Well, then your knees bothering you, and then your low back follows. And then it's just, this snowball effect. And then you're trying to, figure out what happened first. It's like the chicken and the egg argument. And it can go both ways. Someone with a knee problem could end up with a foot problem, but certainly, the foot is, that's what meets the ground for us as humans. And so any little bit of problem there, and if it's unrecognized and untreated, certainly will have as much of a downstream effect on the rest of the body, particularly the lower body, as anywhere else.
Yeah, I mean, essentially, movement starts from the ground up. So it makes sense to build from the ground up, since that's how we interact with the world and engage in things. And, I think the hypothetical question, as you kind of alluded to, is it movement in a different matter, movement in a different method that we're used to that causes pain, or is it pain that causes us to move differently? And
yeah, I think it can be a combination of both, honestly. But I
yeah,
think a lot of times you start getting some discomfort, and whether you realize it or not, you start to subconsciously alter the way you're walking, and that can have a significant effect, a domino effect, upstream throughout the lower extremity and into the back.
yeah, no, definitely. And again, I think a lot of injuries, not all of them, but a lot of them can be managed or prevented with adequate training, or prehab, or whatever kind of injury prevention term you want to throw at it. And that's something that I just see often missed at the foot and ankle complex in general. I don't see a whole lot of strength and conditioning guys addressing toe extensor strength, or toe extensor range of motion, when they're doing their programs. We focus on big groups like the quads, the hips, the things that are going to really propel us forward. But in reality, I like to think that the foot is just as important to all of those things as well. And I think it's funny too, because we kind of train the foot with these different devices, foam pads, or different stability ball type things that effectively remove our proprioceptive input into the ground, and then expect for us to go onto a level surface and somehow have a improved ability to perform on a surface that's completely different than we were just training on or practicing on, if that makes sense.
Yeah, for sure. Yeah, I mean, I think training and like you said, it focuses on I will sometimes call it the sexy stuff, and it's kind of you hear about it in the sports world too, especially with the the ACL epidemic, especially in the young female population, but also males, and how so many of these patients have an imbalance between their quadriceps and their hamstrings, because everyone wants to focus on the strong quads, but no one's really focusing on strengthening their hamstrings. And for that matter, stretching. I mean, everyone's trying to get stronger and faster, not necessarily focusing on stretching. And so I see so many injuries that, almost undoubtedly result from inadequate stretching, particularly involving the posterior chain and, the heel cords on up through the hamstrings. It's just almost everyone I see is tight there. And so I couldn't tell you how many times per day when I'm in the office, emphasizing the importance of stretching their Achilles and for that matter, their hamstrings too, because it can make such a huge difference, just regular stretching on your body's fun, specifically the lower extremities function.
Yeah, definitely. There's a lot that can be prevented by the right care and right attention to detail on a lot of those things, like you just mentioned. There's some things that I find kind of develop in athletes over time, and I think there's arguments that maybe they could be prevented, and there's also cases where they really can't be prevented there. When it comes to something like, say, compartment syndrome, I've seen cases that kind of develop like acutely, just in response to a certain event or trauma. And then I've seen some that kind of develop over time and, response to like chronic exertion and that sort of thing. But for those listening, maybe they haven't heard of compartment syndrome before, maybe they're not really sure how to define it. How would you kind of explain compartment syndrome to someone, Jake?
So compartment syndrome, we see it enough. It's a very serious problem, particularly in the traumatic or acute setting that you alluded to. There, we think of it in two different ways. There's the acute traumatic compartment syndrome that can develop, and then there's the compartment syndrome that can develop more in a chronic exertional state. So starting with, kind of acute and traumatic, I mean, usually it's associated with some kind of injury, whether that's just a soft tissue crush injury or, a bad bony injury. And there are certain types of injuries that we have a very high or have a high association with it developing. But essentially what it entails is all the muscles, no matter where they are in your body, but lower leg, upper leg, in the upper extremity, they're all isolated into compartments. And each compartment has a different number of muscles in them. But let's take the lower leg, for instance, because that's generally the most common area we see compartment syndrome develop, both from an acute traumatic standpoint, but also chronic exertional. There's 4 different compartments. And so what they are is just essentially what it implies. It's a compartment where you have a number of different muscles that are all kind of together inside this layer of tissue that we call fascia. The fascia is this very hard, it's soft tissue, so it's pliable, but it is very strong. And it will allow for some swelling, but at some point it has its limits. So if you can imagine, trying to stuff, a lot of things, say, into a shopping bag, at some point that shopping bag can accommodate so much, but then ultimately you're going to start to crush some of your groceries if you're trying to put too much in it. And so what happens is, and again, kind of starting with the acute traumatic situation, something has happened to create a significant amount of swelling. It could be that there's bleeding going on. It could be just a really bad crush injury or bad bony injury. But whatever has happened has led to a significant amount of swelling. And so what's happening is the muscles are swelling up and swelling up and swelling up to such an extent that the fascia has reached its limits, but the muscles are still continuing to swell, and the pressure is building up within these compartments. And all of the muscles, all of the nerves within that compartment are relying on blood flow coming in to them so that they can continue to survive. And what happens is the pressure becomes so great that it chokes off the blood supply to those structures. The nerves being the most sensitive to that disruption of blood supply, but the muscles soon to follow. And obviously, if you choke off nerves that are innervating the muscles, then you've lost the muscle function. And so what happens is you lose this blood supply because the pressure has essentially kinked off the arteries that are supplying the blood. So for instance, if we're focusing on the anterior compartment of a lower leg, one of the most sensitive signs for diagnosing compartment syndrome and getting into it early is simply taking the big toe and moving it up and down, and specifically stretching it into a flexed position. So we're calling that passive stretch, and specifically of the EHL, the extensor hallucis longus tendon. And something as simple as that could cause a patient who's in the setting of compartment syndrome to essentially want to jump out of bed in pain. So they get pain out of proportion to relatively innocuous things. And that's the most sensitive sign to look for, because other hallmark symptoms, they talk about the P's, paresthesias, pain out of proportion is one of them. But paresthesias, we were always taught, once paresthesias, which is essentially a fancy way of saying tingling and the development of numbness, once that has set in, there's some irreversible damage that has already potentially set in. And so the horse may be out of the barn there. Obviously, pressure is another thing. These are generally extremities that are very swollen and almost rock hard to the touch. But it is a condition, especially in the acute and traumatic setting. It's one of those things that if you're suspecting someone has it, then you got to go in and treat it, because waiting on it can have irreversible damage and consequences, such as foot drop, which is permanent. And so it is a devastating condition. It is the source of, unfortunately, many lawsuits in the orthopedic world, because it's a condition that, if left unrecognized and untreated, will cause lifelong disability. And so this is a middle of the night. You get a call about this. You're going right into the hospital, and you're not messing around. You're going to get right to the OR to open up those compartments and allow more of that swelling to occur, so that those blood vessels are not getting kinked off as much as they are with the fascia being intact. And so, like I said, the lower leg is where we see it most commonly. And we alluded to it earlier, but there's also the phenomenon of chronic exertional compartment syndrome, where that is not in the acute traumatic setting. That's something that's more something that has kind of developed over time. We mostly see it in patients in their 20s into their early 30s, but it can happen in any age group. But that's typically where we see it most commonly. These are typically athletic individuals who, during the course of their attempts to work out and advance their physical activities, start to develop debilitating pain. And a lot of it can be the same symptoms as someone who has acute traumatic compartment syndrome, but maybe to a lesser severity. So they're not necessarily writhing in bed in discomfort, but again, we'll focus on the lower leg. They develop pain to the point where they have to stop doing what they're doing, most commonly something like running. But they will also get associated numbness, because, again, for that same reason, some of the nerves are getting a little bit choked off. They're not tolerating the pressure of the compartments well. Either that's the case, or the blood supply to the nerves has been diminished to some extent. And nerves are very sensitive to any level of change in their environment. Most commonly, where patients will feel that is kind of on the top of their foot and in between the first and second toes, but it can really happen anywhere. And then ultimately, once they sit down and rest, the symptoms resolve. So it's not something that typically bothers them at rest, although the numbness and tingling, just as easily as it can start up, it can take a long time to resolve. So a lot of times patients will come in saying, they rest for a few minutes and their pain subsides, but they still have this lingering tingling or numbness. And so it's a diagnosis that generally, from the history alone, just talking to a patient, you develop a sense right away of what's going on. Some patients I've had, including one that a patient that you and I have shared, will have a family history of it. Now, that's not necessarily a common thing, but I have seen patients where parents have had it, and so there may be some genetic component just in terms of how the makeup of their musculature and their compartments is that predisposes them to that problem. But most of the time, it shouldn't be seen as something that has a genetic predisposition to it, but it can. And so history is very important. Talking to patients, getting an idea of what they've been experiencing, what predisposes them to get these symptoms, what allows it to improve. This is not something, a lot of times when patients come in and see me, they're automatically going to get x-rays. So, we'll oftentimes have x-rays, but you're not going to really see anything on an x-ray. I've had patients come into me with $1 million workups. They've had MRIs of their legs, their feet, their spine. They've had EMGs done, which are nerve studies where they get stuck with needles up and down the legs and trying to figure out what's going on. All of that stuff, generally speaking, is not going to give you any sense as to whether or not they're experiencing chronic exertional compartment syndrome. They're unnecessary studies to get. Now, the one case where you may want to get an MRI is if you're suspecting that maybe there's like some mass lesion or mass effect on a nerve, if it's, specifically if it's like a focal finding, like it's not just like their whole leg or the whole foot hurts, but it's a specific finding involving a specific nerve. In some cases, something like a ganglion cyst could be pushing on the nerve. And so if you're suspicious of it, it's not wrong to get the MRI. But if you're getting an MRI you're not going to get an MRI, I should say, to diagnose chronic exertional compartment syndrome, because it's just not going to show you anything. So the only reason to get an MRI would be if you're suspecting that there's something pushing or pinching on a nerve. Really, the best way to diagnose chronic exertional compartment syndrome is to do compartment testing. And what we do with that, and usually you want to find a physician who is well versed in this. I have partners that I will send patients to be tested. But what they do is they'll have the patient, exercise for a period of time, and they'll measure their compartments prior to their exercise, have them build up, get into a strenuous run. And then, especially if the patient reports that they've started to develop the symptoms, they'll stop the exercise, wait a minute, remeasure the compartment pressures, and then look at it again at 5 minutes after the cessation of exercise. And there's certain parameters that have been defined by studies that were done in the distant past that kind of we use as markers as to whether or not they truly have compartment syndrome. Before I get into those numbers, the way which we do that is not something that patients get super excited about. It involves sticking needles into the legs. And again, we'll focus more on the lower leg because that's where we see this by far the most commonly. And so there's 4 compartments in the lower leg. And so that involves sticking the needles into 4 different places. These are specific needles that have like a pressure transducer associated with them that can give you a pressure reading. And so what we look for is when we measure these compartments at rest, we're looking for a measurement below 15 millimeters of mercury. Anything above that reading would be considered consistent with chronic exertional compartment syndrome. And then we look at it, or concerning at least for it, because again, that's a resting measurement. So we do have to kind of take that with a grain of salt. We're more looking at how do the compartment pressures change following the initiation of strenuous exercise. So at 1 minute post-exercise, if that number has jumped above 30, then that's, considered diagnostic. And at 5 minutes after the cessation of activity, 20 millimeters of mercury is the cutoff. So again, if it's above that, then we consider that consistent with the diagnosis of chronic exertional compartment syndrome. So like I said, we're measuring 4 different compartments. So you can have it in 1 compartment, you can have it in 2, you can have it in 3, you could have it in all 4. And so what I don't necessarily, I focus on what the resting tension or pressure is only as a way to kind of help me guide my interpretation of what the post-exercise measurements are. And so I'll look at both the 1 minute and the 5 minute exercise post-exercise measurements. And if either one of them are elevated, then I will, consider that diagnostic of the condition. This is something that, listen, you could try to manage this non-surgically, but it's very unreliable. Sometimes people talk about like, myofascial, therapy or deep massage, but at the end of the day, nothing's really changing the overall architecture of that lower leg, the architecture of the individual compartments, the pliability of the fascia to some extent. I don't know that anything's necessarily going to change that to a significant degree. And so non-surgical management is, in my opinion, pretty unreliable. It's one of the few things that, I'll tell a patient, even if they haven't tried it, I'm not going to make them try it prior to giving them the option of surgical intervention. And so with the surgery, what we do is we identify, okay, what compartments are the problem? And I do want to make sure that matches up with the patient's reported symptoms. And as long as that's the case, we bring them to the operating room. It's an outpatient procedure. I am not opposed to operating on both legs at a time. It's very common to see patients come in and both of their legs are pretty much equally affected. So I'm not opposed to doing both at the same time. And we basically make incisions overlying whichever compartments are the problem. And so, like I said, in the lower leg, there's 4 compartments. You have your anterior compartment, a lateral compartment, and then 2 posterior compartments, one that's deep and one that's superficial. We gain access to the posterior compartments, both deep and superficial, through a medial incision that's kind of centered over the mid aspect of the lower leg. Whereas if we're looking to attack the anterior and lateral compartments, that's through an incision over the lateral aspect of the lower leg. Once again, kind of mid aspect of the leg. There are some surgeons out there who will do this endoscopically. And then there are some surgeons who will be able to do a release of all four compartments just through an isolated lateral incision. I think one of the biggest issues with the surgeries in terms of incomplete relief of symptoms is an incomplete release of the fascia. So this is not something that I've really developed a strong desire to learn endoscopic releases. Obviously, the benefit of less, in theory, less risk of wound complications because you have smaller incisions is appealing. But, I do worry about, how good of a release are you getting? I've seen even patients who have had open releases through, maybe the surgeons will make a couple small incisions, one up higher in the lower leg and one down distal. You do wonder, sometimes did they really adequately release the entire compartment? Because you can see cases of recurrence. And so I am a bit will release almost close to the entirety of the compartment. You do have to, certain compartments, you have to be very mindful of certain important structures to identify and make sure that you don't inadvertently injure during the process of your compartment releases. And one of the most common structures is the superficial peroneal nerve, which provides the sensation of the dorsum of the foot, and it perforates the fascia in the anterolateral aspect of the lower leg, oftentimes perforating through the fascia of the anterior compartment, but it can also emanate through the raphe that divides the anterior and the lateral compartments. So you do need to be very mindful. I always find that nerve and make sure that I'm very careful to work around it when I'm doing my releases. And sometimes what you'll also see is some herniations of the fascia. So the patient has developed like a herniation in their fascia, which is essentially an opening, and their muscle kind of herniates through it. And so if that's the case, I'll just kind of just complete that herniation to fully release the compartment. So, I kind of rambled on there, but, I can certainly get into like my recovery if that is something, kind of to, bring this to a close. And then certainly if there's specific questions, we could, kind of obviously hit them.
Yeah, you covered so many great things there, Jake. And just to kind of recap a little bit, so your cut score for, diagnosing compartment syndrome was a 30 millimeter mercury change shortly after exercise, and then 5 minutes afterwards, it was like a 20 millimeter cut score. You talked,
yeah, and it's really an absolute value. They talk about like pressure measurements in the acute traumatic setting,
yep.
Where we use what we call a striker needle, which to measure compartments, and that's where we look more at like the delta or the change in the compartment pressure relative to the diastolic blood pressure. However, my argument has always been, if you feel like you need to put a striker needle into someone in the acute traumatic setting, don't waste your time. They need to be released. And so, but technically the textbook answer is, yeah, there's certain measurements that you're looking at in terms of what the compartment's measuring relative to what their diastolic blood pressure is. But when we're talking about chronic exertional compartment syndrome, we're just focused on absolute values in terms of the pressure. We're not necessarily comparing it to their blood pressure or anything like that, or looking at change per se. It's more just, hey, did it jump above 30 at 1 minute post-exercise, or is it staying above 20 5 minutes after the cessation of exercise?
Right. And then you mentioned too about, the passive stretch on the first toe being one of your key indicators. You mentioned the 5 Ps there: pain, pallor, paresthesias, paralysis, and pulselessness. And you mentioned a little bit about the muscle herniations as well in the surgical standpoint. I've never felt one myself, but I've heard of people claiming to be able to palpate herniations on certain exam. I've never like felt that myself, but I wasn't sure if that was something you felt like on a patient, like anterior tibia area or anything like that.
Yeah, I mean, it's not super common. Where we see it, at least I've seen it most commonly, is right around where the SPN the superficial perineal nerve comes through, pierces the fascia of the anterior compartment, or if sometimes it'll pierce through the fascia of the lateral compartment, or through that raphe that divides the anterior and the lateral compartments. It's funny you ask that because literally it's not common, so I don't see it very often. But literally today, I operated on a patient. She's a 39-year-old who's had symptoms for over 10 years. It started when she was training for a marathon and just never quite subsided. Now, she's not like a heavy-duty runner at this stage in her life, but it has interfered with her ability to be as active as she would like. And this was not an issue of chronic exertional compartment syndrome because her findings were focal to the superficial perineal nerve. But on her exam, just feeling down her leg, as you got to basically the distal aspect of the lateral side of the anterior compartment, there was a noticeable lump there, but it was a soft lump. And that's correlated where her symptoms were developing. And she had radiation up proximally along the course of the superficial perineal nerve. And so she had come to me, she was referred to me by a local sports surgeon who had previously ordered an MRI, which, the MRI showed like a questionable herniation of the musculature. It certainly wasn't dramatic. It was more appreciable on her physical exam. And so I actually operated on her today because her symptoms were refractory to conservative measures. Opened her up, and sure enough, she had a fascial defect off the nerve. It was impressively swollen distal to where that compression was, and then proximally appeared more normal. And so I essentially just released that fascia to kind of release all compression on the nerve as far up as I could go, kind of tracing it all the way to where it kind of dives deeper into the anterior compartment of the lower leg. So this wasn't necessarily an issue of compartment syndrome, but it was a fascial herniation where there was a defect in the fascia. And anytime she tried to do something strenuous, the muscles obviously swell, they get bigger, and it was just causing even more choking off of that nerve, which was already getting choked off because the muscle was coming through that herniation, as was the nerve, and the nerve was getting pinched against this hard, fibrous edge of where the fascia was still intact. And, some people will talk about, like, do you try to repair that herniation? Specifically when there's nerve issues, if that nerve is getting pinched there, I am not a fan of repairing that hernia because in all likelihood, you're not going to get an improvement of their nerve issues, and you may actually worsen it. So I will release and essentially make that herniation a little bigger, but it'll be less focal. And so therefore, in theory, it should be less symptomatic.
Yeah, that's interesting. Wow. I didn't even know that. We talked before this, and we didn't even know we had a plan for that. That's awesome.
Yeah. Like I said, uncommon, but it'll feel that little focal area of protuberance. And it's sometimes the patient may or may not have something similar on the other side if it's but oftentimes it's like a unilateral finding, but not common. But your physical exam is kind of the most sensitive thing in terms of diagnosing it. Like I said, this patient came with an MRI. It was very unimpressive. But if you had even further doubts, ultrasound is another great modality to utilize to kind of further investigate something like along those lines.
Yeah, no, definitely. I think having the ability to get real quick musculoskeletal ultrasound, get a real-time image is certainly a game changer there. I also like how you touched on the various incision sites and the various means of incisions. So whether that be opening everything up, kind of like you mentioned you do, versus the endoscopic and that sort of thing. I'm curious, if you do your full open procedure to fully release pressure from the compartments, over time things are going to heal, but fascia as a connective tissue, it's got proprioceptive qualities to it as well. Do you see any kind of long-standing implications from a fully open compartment syndrome, fasciotomy or surgery, from kind of disrupting that fascia, like any long-term things from a proprioceptive or other fascial quality thing?
It's a good question. I do get asked that by patients. I mean, personally, this isn't like a terribly common problem. So, again, I'll say this with a grain of salt, but or you can take this with a grain of salt, but I have not seen that to be the case. personally, but maybe it is there, and I'm just not recognizing it, or patients aren't recognizing it. But especially, like I mentioned, these are generally young athletic patients. The chronic exertional compartment syndrome, again, we'll focus more on that. So I am a big believer in having them do physical therapy, because I do believe it can help them get back to their desired activities more quickly, less risk for re-injury. Like you said, if there is any loss of proprioceptive ability, potentially doing PT can help to restore some of that. Like I said, I haven't necessarily appreciated that, but maybe it is happening, and I'm just not recognizing it.
Yeah. I've been kind of diving into the fascia world a lot more lately. Shout out to the Rude Rock guys, the fascia training specialists. And it's really fascinated me how, in a lot of our training, we kind of forget that. But in the surgery like compartment syndrome, fascia is kind of the name of the game. So I've kind of always been interested by the longstanding implications there. But ultimately, I think you're right. I think that the body itself has an incredible ability to regenerate, repair, and rebuild. And, what once was, quote unquote, broken or traumatic, your body's going to find a way to rebuild it and replenish and get back to where you wanted to be before. At least most of the time it does. I think there are some rare cases in the conversation of compartment syndrome where other nerve entrapments or arterial entrapments can develop as well, and some of those have irreversible effects, if I remember correctly.
Yeah, for sure. I mean, it's certainly, your physical exam goes a long way in terms of detecting if there's any concern for specific nerve entrapments. Like I said, the anterior compartment is the most common compartment when we're dealing with chronic exertional compartment syndrome. So, like I said, that's the compartment. I'm always finding the superficial perineal nerve when I'm releasing that compartment, because that's probably the most commonly compressed nerve. But I do see a number of patients during the course of a year that have symptoms consistent with compression or entrapment of the common perineal nerve at the level of the fibular neck. So I probably do between 5 and 10, probably more close to the line of just a handful. But patients who have that, those are patients that I do send for an EMG. Now, that EMG may not be super diagnostic, but I like to have that diagnostic information at my disposal before I take them to the operating room. But usually it's a diagnosis based on their clinical exam. And essentially, it's a surgery that involves releasing. There's multiple fascial septations that can create an environment of compression to the common perineal nerve further up the leg around the fibular neck. And so I will do those releases. Again, that's kind of a different entity than the chronic exertional compartment syndrome, but not too dissimilar in terms of patients' symptoms and how what I do to rehabilitate those patients post-operatively.
And you mentioned too, on the outcome side, that there's a chance that compartment syndrome can reoccur, but having a tendency to open all of the compartments and get a full release tends to reduce that risk. I don't know if you know any numbers off the top of your head, but what's the recurrence rate, I would say, for some type of compartment syndrome bearing no activity modification and return to where someone was prior to surgery?
Yeah, so generally with the literature, and it's not something that's been super extensively studied over the course of time, but recurrence rates or success rates, I guess, depending on how you define it, are over 80-85%. I would say, fortunately, I've really had pretty good success in my patients, but I have not had to take a patient back to the operating room. We've had some patients have some minor setbacks, but they've been able to overcome that through some physical therapy and changes in their exercise and workout routines. But it's generally a very reliable surgery. I think the biggest risk is skimping on the release, or trying to be too cute with how you're going about releasing the fascia and getting an incomplete release, or not recognizing associated nerve entrapment. And I think that's where you see probably the highest rate of recurrence. There is literature that has described that patients who have all four compartments involved, and specifically involvement of the posterior compartments, have less predictable or worse outcomes and higher recurrence rates. It's again, in my own personal experience, certainly those patients tend to take a little bit longer to get full resolution of their symptoms when they have all four compartments involved. I also tell patients that typically the longer things have been going on leading up to the surgery, the longer it may take to get better. But I've had a number of patients where, like, literally they've had the surgery, and after they get over the temporary increase in discomfort that comes with just the surgery itself for the first week or two, they see a very noticeable difference and improvement in their symptoms almost right off the bat, and they
Yeah,
tend to be very happy patients.
that's exactly what you want to hear.
Yeah,
That's
for
a
sure.
great thing. And you mentioned a few times here that you push for some type of PT involvement as well post-operatively. What kind of things do you look for from a PT who's rehabbing one of your patients after a compartment syndrome? Is there like, are you a protocol guy? Are you a timeline versus criterion guy? What kind of things do you want your PTs to be doing, addressing, avoiding, that sort of thing?
Yeah, I mean, I don't, for my chronic exertional compartment syndrome patient, I don't really have a specific protocol. I mean, I let them walk on their affected extremity right away. I do warn the patients, especially if I'm doing bilateral lower leg compartment releases, and especially in the patients who are having all four compartments released simultaneously on both sides. I warn them, like, those first 2 weeks, when you have both sides done at the same time, that can be a little bit rough. But it's just like someone who has both knees replaced at the same time compared to one at one point and then followed by one at the other point. You can take the argument of, yeah, it's going to be a rougher recovery early on, but you're killing two birds with one stone and potentially can get back to normal more quickly without having to then come back to have the other side done. But once the 2 week mark, we check their incisions. As long as everything looks good, I let them ramp up their activities after that first 2 weeks, because I do tell them, take it easy for the first 2 weeks and try to minimize how much they're up and about. Try to keep swelling to a minimum. As long as they look okay at the 2 week mark, I let them kind of ramp up as they feel comfortable. But I do tell them it should be a slow, gradual resumption of activity. And a lot of times, from a therapy perspective, depending on how good the patient looks at 2 weeks, I sometimes may wait until the 6 week mark to let them get into PT, just to once again give them some time to kind of just get back to their ADLs relatively well before they try to start hitting it hard. But a lot of it comes down to more just sports specific. What are they trying to get back into, and trying to gear their therapy towards that. But proprioception is a big thing. I'm a big believer in that. And otherwise, just strengthening and like we talked about at the beginning, stretching and the importance of stretching, and making sure these athletes have a good sense of how they should be stretching, and what things they should be looking out for and working on that maybe even their athletic trainers at school aren't focusing on.
Yeah, I completely agree. And I think all the points you just hit on are huge, Jake. It amazes me how often I see PTs, though, who get so caught up in the end goal of the sport that they end up missing some of the basic steps along the way to get there.
Mm-hmm.
A different patient example, this individual was not compartment syndrome, but different injury to the foot ankle complex. Came to me after being discharged by a different physical therapist, had 27 degrees of closed chain dorsiflexion mobilization on the affected side and over 40 on the unaffected side. And they discharged him, said nothing more that we could do for this individual, that sort of thing. And it just left me scratching my head. It's like, we didn't even hit the basic range of motion requirements for functional activity. So it amazes me again how often we miss those basic things like range of motion, or how often we forget about the importance of having strength before we start jumping and landing and cutting and doing all the fun things. And that's something that I definitely see value in myself is, I'm not a guru, I'm not the smartest person around. I really don't know everything. And that's why I'm still trying to learn as much as I can. But I've found in general, if you hit the simple things really well and you don't miss anything, 9 times out of 10, you get a really good result out of it. It's not
Mm-hmm.
rocket science, at least it doesn't seem to be anyways.
Mm-hmm. Yeah, for sure.
And I will say I've heard in the past different surgeons are kind of mixed on different manual therapy techniques over the incision sites or after compartment syndrome. I wasn't sure if you've heard anything about that yourself. I've heard mixed thoughts on any type of like soft tissue compressive manual techniques over incision sites for a period of time. I've heard mixed things on dry needling in the lower leg because of the potential of getting a needle into like a neurovascular bundle in the lower leg. I wasn't sure if you had any thoughts on that.
Yeah, I mean, I certainly want to make sure the incision is nicely healed before we start to do any kind of like scar massage or anything like that over the incision. But I'm not opposed to it. I don't really have like strong thoughts one way or another. And same thing goes with the dry needling. I mean, I tell patients like because I get asked all the time about like dry needling, acupuncture, cupping, and I tell them, I say, listen, I'm not opposed to any of it. I don't know that it's going to work for you, but you're certainly welcome to give it a try. Just make sure you go to someone who does it regularly and knows what they're doing so that you avoid potential complications, and go to someone who knows more about it than I do, because make sure you do your research, because they can oftentimes, I think, be a better resource to talk to whether or not that patient's condition is going to be something that responds to whatever it is they're looking to check out. So I don't really have any like opposition to any of that, as long as once the surgical wounds are healed, then I really don't have any opposition to any of that. I mean, I do feel very strongly about something like Graston technique, more so for my Achilles tendonitis patients, my plantar fasciitis patients. I'm a huge believer in that. From the standpoint of the compartment releases, listen, I can't imagine Graston's going to hurt anything. Like, it may help them progress. So I'm certainly not opposed to really anything in their recovery. Certainly, especially if the patient feels like it's helping them.
Yeah, no, definitely. And I'll take that a step further. How do you feel about the compressive devices, like the different like leg sleeve compressive modality type things, like the pumps that squeeze, relax, as
Mm-hmm.
like some of a massage effect? I'm trying to think of a specific name of one right off, but essentially they're like these large boot things that go up the leg and compress to
Mm-hmm.
help with like venous return, venous blood flow, lactic acid, all that sort of thing. How do you feel about something on the outside of the leg that's putting, 80, 100 millimeter mercury pressure on the leg after something like compartment syndrome?
Again, once the wound is healed, I'll let a patient try whatever they want. Again, this is not something that I'm regularly telling a patient to do, but certainly if they want to try something like that, they can, by all means, go for it. Like, the nice thing with these compartment releases is there's nothing really structurally that has to heal. It's really, and so my biggest thing is once that incision's healed, you can do whatever you want, as long as it's making you feel better, as long as you feel like it's helping you. So if these devices are making a patient feel miserable, well, then my answer to them is don't do it, because I don't think it's helping you to the extent that you should put yourself through misery to do it. But certainly, along the lines of like the sleeves and things like that, like I have no opposition to anyone doing that, as long as they see benefit from it. But I do tell patients, like, as far as I know, that, I'm, and maybe I'm just not well versed enough in these modalities, but I don't know what the data is to show it. So I said, the worst that could happen, aside from maybe causing some increased pain, is that it just doesn't do anything for you, in which case, don't feel like you need to keep beating your head against the wall and keep trying to do it. But like I said, I really don't have any restrictions on what modalities people try. And I do like to give the therapist kind of free rein to kind of utilize the modalities that they are most comfortable with and what they feel is successful in their hands, to help a patient get to where they need to be.
Love that. Love that. Jake, I feel like we've discussed a lot of different things here in relation to the surgical consideration, diagnosis of compartment syndrome, how it presents clinically, acute versus chronic exertional, the rehab considerations. I feel like we've touched on so much here. Do you have any additional thoughts or anything that we might have missed thus far today?
No, I think we did a good job hitting all the bases. So Yeah, I think we're good.
Awesome. Jake, for people who want to find out more about you or keep in touch with you, how can they find you? Are you you're probably more of a MySpace guy at this point, right?
Well, honestly, to be brutally honest with you, I have as minimal of a social media presence personally as one could have. Facebook was my foray into social media but I got rid of it in medical school when I had to start studying for my board exams, and I realized how much time I was spending on it as opposed to dedicating to studying. And I said, you know what, I'm probably better off not going back on. But certainly, like we mentioned earlier, I'm with the Rothman Orthopaedic Institute, and where I personally see patients is in mainly the western suburbs of Philadelphia. But certainly, contacting us as a practice, and whether it's something in the foot and ankle or lower leg, like we had discussed during today's segment, or we have specialists, that do everything, from the toes all the way up to the neck and into the fingers. So if anyone's having any issues whatsoever from an orthopedic standpoint, and is willing to make the trip to the Philadelphia area, then give us a call.
Yeah, I will definitely vouch for you guys. I highly recommend you guys, especially you, Jake. I think you're very good at what you do, and so far we're batting 1,000. So let's keep that rolling, And
That's right.
we'll link to your Rothman page as well in the description.
Perfect.
So if anyone wants to check out more about you or look at your various research publications there, I know you've done a few different things in regards to Lisfranc injuries and total ankle arthroplasty and that sort of thing. So we'll link to all of that below in case people want to check any of that out.
Great.
Jake, really appreciate your time today. Thank you for coming on.
You're welcome. Thanks for having me, Dan. It's great to be here.
Hey everyone, I want to take a second and tell you all about AliRx. AliRx is a at-home food sensitivity and gut health testing panel. You order online and then receive and complete your test at home for food sensitivities. You then receive a custom report online through your member portal and then receive personalized recipes and supplements that are catered to you based on your food sensitivities. If this is something that interests you, you can check out the link and description in my bio, and you can use the coupon code capital D, capital B, RAUN, capital RX, so D Brawn RX, at checkout to save yourself 20%. Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.